Good morning, respected teachers, seniors, and colleagues. Today, in the Journal Club, I am going to present the journal on the POLO trial. The POLO trial is a landmark trial. It was published in the New England Journal of Medicine in 2019, June 2. Setting the scene, the poor prognosis of pancreatic cancer is due to the late presentation of the disease. Most of the patients present in the advanced stage of disease when the disease is unresectable or in the metastatic disease. Median survival of metastatic CA pancreas when treated with doublet or triplet regimens is less than 1 year, and for single agent treatments, the median survival is only 6 months. The toxicity of most active combination chemotherapy regimens limits the duration of exposure to patients, even if the patient is benefiting from the treatment. Such as if the patient is treated with FOLFIRINOX, the neuropathy or the hematological toxicities that develops after 4 to 6 months of treatment limits the further exposure to all the three combination agents. The limited absolute benefit and the significant toxicity strongly suggest that improving the results of initial therapy of metastatic pancreatic cancer constitutes an unmet medical need. Approximately 3 to 10% of pancreatic cancer patients have a positive family history of cancer. Among unselected cases of pancreatic adenocarcinoma, pathogenic mutation in BRCA2 are found up to around 2% of patients, and in mutation in BRCA1 gene in up to 1% of patients. In familial pancreatic cancer, the BRCA2 mutations are found in 5 to 10% of the patients, and BRCA1 mutations are found in 1 to 2% of the patients. Now, coming to the mechanism of PARP inhibitor, we all know that during the cell cycle, during the S phase, the DNA is synthesized. During the DNA synthesis, there is single strand break occurs, which is necessary for the DNA replication. These single strand breaks are repaired by the BER, that is base excision repair pathway. The PARP, that is poly-ADP ribose polymerase. This is an enzyme which participates in the BAR pathway. So once there is a single strand break, this is repaired by the BAR pathway, and the cell can go on. The cell can continue in the cell cycle. However, if there is if we give the PARP inhibitors, then this PARP inhibitors entrap the PARP, which then the single strand break then cannot be repaired by the base excision repair pathway. And once there is an SSB, then a double strand break occurs. Then the double strand break is generally repaired by the HR pathway, that is the homologous recombination pathway. So in patients with BRCA mutation, the BRCA gene encodes for a protein which takes part in the HR pathway. So once the patient is BRCA mutated, then they are BRCA protein deficient, so they are HR deficient. So once they are HR deficient, so they cannot repair the DSB. So ultimately, once we give the PARP inhibitor, then these single strand breaks are converted into double strand breaks, which cannot be repaired because they are HR deficient, and then ultimately, because of this double strand breaks which accumulate and the cell dies. This is the basic mechanism of the PARP inhibitor. Now, olaparib maintenance, we have seen a studies in breast and ovarian cancer. In the left side, this is the Olympia trial. On the right hand side, this is the SOLO-1 trial. We have seen olaparib maintenance used in the breast and ovarian cancer, which has significantly increased the progression-free survival in these patients. In the Olympia trial, in the left hand side, you can see the PFS curves. The PFS curves are beautifully separated. And the right hand side, this is the SOLO-1 trial. We can see the PFS curves of the olaparib versus placebo. This is beautifully separated.
Rupjyoti?
Yes, sir.
What was the inclusion for breast cancer? It was not in the maintenance setting.
Okay.
Ovarian was in, if I'm not wrong, ovarian was in the maintenance setting. That
Yes,
is
sir.
to
In the yes,
in
sir.
breast it
Ovarian.
is in no more than 2 lines were their inclusion criteria.
Yes, sir.
Okay.
Before the POLO 1 study, which was a phase 3 trial, the phase 3 data was collected. This was study 42. This was a single arm phase 2 study of olaparib. The dose was 400 milligram BD. Patients with germline BRCA mutated malignancies across multiple tumor types were included in the study, not only the pancreatic cancer. The patients who had a pancreatic cancer was treated with a prior gemcitabine regimen in all the cases, and over half of the patients received a platinum-containing regimen. The overall response rate was 22%. The PFS was 4.6 months, and overall survival was 9.8 months. The greatest benefit from olaparib was seen in patients whose tumors had not progressed on a prior platinum treatment. And in this case, the patients who had received a prior platinum treatment and did not and had a stable disease or response, the overall responses in this setting was 33%. The PFS was 6.4 months, and the OS was 13.1 months.
So this was the hypothesis generating trial where they found that maximum benefit was in patients who were already chemosensitive.
Yes,
So
sir.
that is why they did this next trial in the same setting where they have taken platinum sensitive patients.
Yes, sir.
Go ahead.
Coming to the standard coming to the NCCN guidelines for treatment of metastatic pancreatic adenocarcinoma, in patients who are a good PS, that is 0 to 1, the clinical trial is preferred or systemic therapy. After 4 to 6 months of systemic chemotherapy, then maintenance therapy, they have included multiple settings. Then we can continue the same therapy if the patient does not develop any toxicities. Then we can go for other maintenance therapy strategies, or the patient can be included in a clinical trial, or we can give a chemotherapy holiday. After this trial, they have included olaparib as a maintenance therapy only for germline BRCA1 BRCA2 mutated pancreatic cancer patients who are metastatic. The primary objective of this study was to find out the progression-free survival. The secondary objectives were to look at overall survival. The second PFS, which is time from randomization to the second progression. TFST, time from randomization to the first subsequent therapy or death. TSST, time from randomization to the second subsequent therapy or death. Then time from randomization of treatment to discontinuation or death. Overall response rate and quality of life. Inclusion criteria in the study, the important inclusion criteria were the patient should be 18 or more than 18 years of age. The patients should have histologically or cytologically confirmed pancreas adenocarcinoma. The patients must have a documented mutation, documented germline mutation in BRCA1 BRCA2 gene that is predicted to be deleterious or suspected deleterious. Patients who are on treatment with a first-line platinum-based regimen for metastatic pancreas cancer, we have received a minimum of 16 weeks of continuous platinum treatment and have no evidence of progression. That is, the patients must have received 4 months of therapy and should be platinum sensitive. They should not have any progression on this therapy. Patients who have received platinum as a potentially curative treatment for a prior cancer or as adjuvant or neoadjuvant treatment for pancreatic cancer are eligible provided at least 12 months have elapsed between the last dose of platinum-based treatment and the initiation of the platinum-based chemotherapy for metastatic pancreas cancer. And the ECOG PS should be 0 or 1. Important exclusion criteria were the germline BRCA1 and BRCA2 mutations that are considered to be non-detrimental, such as variants of unknown clinical significance, VUS, variants of unknown significance, or benign polymorphism. These were not included in the study. If the patients had progression of the tumor between the start of the first platinum-based chemotherapy and prior to randomization, those patients were not included. If the patients received any cytotoxic chemotherapy or any non-hormonal targeted therapy within 21 days of cycle 1 day 1 olaparib, then they were also excluded. If the patient received any previous treatment with PARP inhibitor, including olaparib, they were not included in the study. The trial was designed as a randomized trial. It was double-blind, placebo-controlled phase 3 trial, which was conducted in 12 European countries and in 119 sites. With the use of a central interactive voice response system that incorporated block randomization scheme, the patients were randomly assigned in a 3:2 ratio to receive maintenance olaparib tablets. The dose was 300 mg BD or matching placebo. This maintenance trial intervention was initiated 4 to 8 weeks after the last dose of first-line chemotherapy. The intervention was continued until the occurrence of objective radiologic progressive disease or if the patient had unacceptable toxicities. Crossover to olaparib from the placebo was not permitted, and after discontinuation of the trial intervention, subsequent therapies were administered at the physician's discretion.
Why do you think they didn't allow crossover to olaparib?
So if the patient had progressed when on the placebo, then they gave olaparib at the physician's discretion, but they is included in the trial.
No, they have written here, na? Crossover was not allowed. What? Go to back to your
Yes, sir,
previous
they
slide.
have not included in the anal.
Now, I am not going to result part. I know that.
So they had if the patient
what was their
progressed on
intention?
the placebo.
So what was their intention? Why didn't allow? Initially, they designed in this manner. Just thought if they would have allowed, what would have happened? Their primary endpoint was PFS, right? So PFS difference could have come even if they would have allowed a crossover.
Hello.
Hello.
Yes, sir.
So PFS benefit would have come even if they would have allowed crossover. They didn't allow crossover. Why?
Because that may impact in the PFS too, sir.
Maybe, and even OS also. And if supposedly they allowed crossover, supposedly, and OS comes the same in both the arms, then people wouldn't have used in the maintenance setting. We would have kept it for second line setting, right? Sure, go ahead.
So around 3,000 patients, that is 3,315 patients, were assessed for eligibility in the trial. Out of these, 247% had a germline BRCA mutation. That is almost around 7.5% of the patients. Out of this, 167 patients provided a written informed consent, and out of this, 13 were excluded because 11 did not meet the eligibility criteria, and 2 declined to participate. So ultimately, a total of 154 patients underwent randomization were included in the efficacy analysis. Out of this, 92% were designed to receive olaparib, and 62% were designed to receive the placebo. Among the 92 patients who received olaparib, 60 patients discontinued olaparib because 43% had a objective PD, objective radiological progressive disease. 12% had a progressive disease determined by the investigator. 4 patients had an adverse event, and 1 patient withdrew. And among the 62 patients who had received placebo, 53 patients discontinued placebo because 40 patients had objective radiological PD. 9% had PD based upon the assessment by the investigator. 2 had adverse event, 1 withdrew, and 1 did not meet the eligibility criteria. At the end of data cutoff, 30 patients were receiving olaparib and 8% were receiving the placebo. It was determined that with a sample size of 145 patients, 87 cases of disease progression or death would provide the trial with 80% power, and one-sided significance level of 2.5% to show a significant difference in the PFS between the olaparib group and the placebo group, achieving a hazard ratio for disease progression or death of 0.54. The efficacy, the data on efficacy are analyzed with the intent to treat population. Data on safety are summarized in the safety population, that is the patients who have received at least 1 dose of the trial agent, and the data on health related quality of life are analyzed in all patients. The primary analysis of progression-free survival was performed with a log-rank test with a calculation of hazard ratio with an accompanying 95% confidence interval p-value. Subgroup and multivariate analysis of PFS are conducted with use of Cox proportional hazard model, and all time to event curves are generated with the Kaplan-Meier method. Overall survival and overall progression-free survival, and second PFS, second progression-free survival was analyzed with the same method that was used for progression-free survival. That is the log-rank test. Now, baseline characteristics of the patient. If we see both the groups, that is the olaparib group and the placebo group, it is quite beautifully matched. The median age is 57 years in both the groups. Then ECOG performance status, 70% of the patients had PS0 and 1% and 30% of the patients had PS1. 2/3 of the patients had Jamlin-BRCA2 mutation, and 1/3 of the patients had BRCA1 mutation. The median duration from diagnosis to randomization was 6.9 months in the olaparib group and 7 months in the placebo group.
So what does this imply?
Almost 80% of the patients had received.
The time from the diagnosis to randomization was 6.9 to 7 months. So what do you think how will you change your practice? How will you imply in your practice? What did they say inclusion criteria?
So only the patients who did not progress on the first line chemotherapy, and who have received at least minimum of 4 months of chemotherapy.
Yes, but still most of the patients included were more than around 7 months. So patients who are maintaining good response even at 7 months, they were included in the trial. Okay, what would be PFS on first line therapy normally?
Yes, sir.
How much PFS do you expect? Overall survival in a metastatic pancreas with FOLFIRINOX or Gemcitabine first line?
So voice.
Am I audible?
Yes, sir. OS is around 1 year. Sir.
Yeah. So PFS is around 6-7 months only. PFS is around 6-7 months, right? So they have taken good patients in this trial.
Yes, sir.
Those good biology disease.
Yes, sir.
Go ahead, Rupjyoti.
And 80% of the patients have received either FOLFIRINOX or FOLFIRINOX variants. The best response to chemotherapy, that is the first line chemotherapy, 50% had the complete or partial response, and 50% has stable disease. Now coming to the PFS curve, we see that this blue curve is for olaparib group, and the red curve is for the placebo group. We see both the curves are beautifully separated. For the initial 4 to 5 months, the curves overlaps one over the another, but however after around 5 months, the curve starts to separate, and the separation is maintained at till the end. And the slope of the curve is highest in the initial 2 to 4 months only. We can see that the median PFS in the olaparib group is 7.4 months, whereas in the placebo group it is 3.8 months, with a hazard ratio of 0.53, with a 95 confidence interval is 0.35 to 0.82, and a p-value which is significant. We can see that at the end of 6 months, in the olaparib group, 53% of the patients did not progress, whether in the placebo group only 23% of the patients did not progress. That is, in the olaparib group, twice the patients did not progress compared to the placebo group. At the end of 1 year, 33% of the 33% patients in the olaparib group did not have any progression, whereas only 14.5% of the patients in the placebo group did not have any progression. At the end of 1.5 years, 27% of the patients in the olaparib group did not have any progression, whereas only 9.6% of the patients in the placebo group did not have any progression. So we can see that after around 5 to 6 months, the patients who did not progress was twice in the olaparib group and compared to the placebo group. Now coming to the subgroup analysis of
why the
PFS,
initial
we
part of
can
the
see
curve
in all the
declined?
subgroups that so the most of the progressive, most of the PD events occurred in the initial 2 to 4 months, sir. Because we can see that the patients has already received 4 months of therapy. Then after that, the median PFS is around, we see in metastatic pancreatic cancer almost around 1 year. So
Yes.
they have progressed before 1 year only, sir.
Yes, good.
In the subgroup analysis, we can see almost all the subgroups have PFS benefit with olaparib. That is whether the patients have received FOLFIRINOX variants or the other variants, or if the patient has received doublet chemotherapy or triplet chemotherapy, or if the patient have received 4 months to 6 months of chemotherapy versus more than 6 months of chemotherapy. If the patient had a partial response or complete response to the therapy or a stable disease, almost all the subgroups had a benefit from the olaparib. And almost in most of the cases, even the confidence interval lies left to the line of no effect. Now coming to the overall survival analysis, an interim survival of overall survival was done at a data maturity of 46%, which showed no evidence of difference in the OS between the groups. The median OS was 18.9 months in the olaparib group and 18.1 months in the placebo group. And the hazard ratio was 0.9 to 1, and p-value is 0.68, which is not significant. And a primary analysis of OS was planned after a data maturity of 69%. That is, if when 69% of the events have occurred, then they have planned the data analysis for the OS, mature OS, which is presented later on in the study.
So why do you think there was no OS benefit?
If we see the OS, the blue curve is for olaparib.
This may answer what Lingraj has asked. When we showed there is around 3 months of PFS benefit, why was there no OS benefit? Anyone else?
Roopjyoti, did you understand my question?
He wouldn't have read it.
Roopjyoti,
Yes, sir.
was the control arm okay for this study? Placebo. Can you go back to your NCCN wala slide? NCCN recommendation.
Sir, in the NCCN recommendation, they have
Go back to slide. Go back to your
there are
slide.
multiple options, sir. If the patient has
Go
responded
back to your
first and
NCCN
chemotherapy,
slide.
then treatment wholly.
Roopjyoti, go back to the slide.
Yes, sir.
NCCN slide.
Yes, sir. I just could not move the slide.
Yes, enlarge it. Full screen.
Sir, in the first line, if they have
Where is that?
in the first line,
stop?
if the patient has not progressed on the first line, then they have also given the chemotherapy holiday as an option, sir.
Okay. So what do you do in clinical practice for those patients who are otherwise fit. And so chemotherapy holiday is patients who have significant toxicities and not going to continue further treatment because of compromised PS. But what is the first thing that they have written? First thing. Above that olaparib thing. Rujati, can you hear me?
Yes, sir. Olaparib is also included as a maintenance only for patients with germline.
And what about
Yes, sir. Now I can. Yes, sir.
continuous systemic therapy? Is there? Rujati,
Yes,
can
sir.
you hear me? So continuous systemic therapy is there, no?
Yes, sir. In the maintenance therapy, they have.
So in this study, placebo was the control arm. That means there was no systemic therapy that was continued for patients who are fit to be enrolled in the study and they had a responding disease to chemotherapy. So my question is, was the control arm correct for the study? That means you have given chemotherapy holiday for the control arm, right? So do you really do that in real practice? Like patients who have received was 6 months of treatment, their PS 0 to 1 as per the study, and they have a stable disease or PR. And what do? You do give chemotherapy holiday for metastatic pancreas? Rupjiti, can you hear me?
Just say what logic will you apply? Meaning, even if you've not treated a metastatic pancreas, in other places, a metastatic patient is doing well on chemotherapy and has good PS ongoing, is responding to therapy, what would be your first instinct to do?
Maybe anyone else who has done GI can answer for us.
Who did debate yesterday? Shashwat and Shashwat?
Yes, sir. If patient tolerates upfront chemotherapy well and there's no significant toxicity, we either plan for continuation of chemotherapy or we give interim maintenance to maintain the response.
Okay, good. And especially when the inclusion criteria said that even after 6-7 months, they had a good PS. We saw that median inclusion till randomization was 6-7 months, and patients were continuing to do well. So we actually withdrew chemotherapy from a very fit patient and made them a control placebo patients. Okay, and that is why there was no OS benefit, the point from where all this started. So even in clinical practice, we will not do. For somebody who is responding and is having good PS also, we will continue chemotherapy. If only PS is poor or patient is not tolerating well, we give a drug holiday. Okay, but this was not the case in the inclusion criteria here. Fit patients who are responding chemosensitive were suddenly said no more further chemotherapy, and that is why there is no OS difference. Most likely, first reason he gave for no OS difference because the data is not mature in till the time of this NEGM publication. And second reason was this, that those who were responding, those who had a chemosensitive disease, there we stopped chemotherapy. Okay.
So Prabhat, in a real world, when you give FOLFIRINOX, how do you continue as a maintenance? You
So we
continue
continue.
5-FU.
We continue FOLFIRI
FOLFIRI.
or 5-FU. We
Okay.
prefer to continue FOLFIRI. Especially oxaliplatin break is required. Otherwise, FOLFIRI, irino also doesn't give some dose limiting toxicities. So we can continue FOLFIRI.
So you bring down the doses of 5-FU and irinotecan by any patients, or you continue the same dose?
Continue same dose as per their tolerance. If they had side effect with 5-FU or irino, then only we will come down. Side effect specific to this drug, then we come down. Otherwise,
But you don't make capyri, right? Because it will cause more diarrhea then. By
so
replacing
capyri
5-FU
is
with
is not a standard of care, meaning
Okay.
For pancreas. So somehow we continue FOLFIRI, but they are not willing for PICC. Then we do write down and note that they are not willing for PICC and then change to capyri.
capyri. Okay. Okay. Continue, Rupjit. Continue.
You're muted, Rupjyoti. Rupjyoti, you're muted.
Am I audible, sir, now?
Yes.
Adverse events. The most common adverse events were fatigue, nausea, and abdominal pain in both the groups, and anemia in the olaparib group. Grade 3 or more adverse events occurred in 40% in the olaparib group and 23% in the placebo group. No adverse events in the study resulted in death. The adverse events led to the discontinuation of olaparib in 5% of the patients and placebo in 2% of the patients. However, no cases of myelodysplastic syndrome, acute myeloid leukemia were reported in either group.
Here is 40%. That is more than 1/3 of your patients will have grade 3-4 toxicities, even with olaparib. Yesterday we were debating that maintenance
Yes, sir.
therapy should be something which should not give
Yes, sir.
toxicity. Right?
Yes, sir.
Go ahead. Go ahead.
Am I audible, sir? Hello.
Yes, yes.
No cases of myelodysplastic syndrome or any acute leukemia were reported in either group. Now, coming to the table of summary of adverse events, we see that almost 96% of patients had any even a grade 3, even a grade 1 adverse events in the olaparib group, and 93% of the patients had a adverse event in the placebo group. So you can see in the box that 40% of the patient had a grade 3 adverse events in the olaparib group, and 23% of the patient had a grade 3 adverse event in the placebo group. And the most common grade 3 adverse event in the olaparib group was fatigue, anemia, followed by fatigue. And the most common grade 3 adverse events in the placebo group was anemia. Then 35% of the patients in the olaparib group needed interruption of the olaparib, and 16% of the patients needed a dose reduction owing to adverse event, and 5% of the patients needed 5% of patients were discontinued because of the adverse event. In the study, no clinically meaningful change from the baseline was noted in the URTC TLQ 330 score in either group, and there was no significant difference in the overall change from the baseline between the two groups. Now, regarding the OS and the other parameters, the ESCO update came in 2021, and this was published in the ESCO meeting. The OS, the measured OS was similar in the olaparib and placebo groups. The median OS was 19 months in the olaparib group and 19.2 months in the placebo group, and the hazard ratio was 0.83 with a confidence interval of 0.56 to 1.22 with a p-value which is non-significant. Overall survival at 36 months was 33% for olaparib and 17.8% for the placebo group. The median second PFS was 16.9 months for olaparib and 9.3 months for placebo.
We saw yesterday also that maintenance therapy.
The OS was the median was for olaparib was.
We saw yesterday also that maintenance therapy does help in increasing PFS2. So here also we can say that, see that. effect.
Yes, sir.
Hmm.
Yes, sir.
Go.
The p value is significant for PFS too. And the PFST, which is time to first subsequent therapy, and PSST is time to second subsequent therapy. The p value is significant. In case of olaparib, the median duration of time to first subsequent therapy was 9 months, and in case of placebo group, the median duration to first subsequent therapy was 5.4 months, and time to second median time to second subsequent therapy was 14.9 months in case of olaparib and 9.6 months in case of placebo. And time to treatment discontinuation or death was 7.5 months in the olaparib group and 3.8 months in the placebo group, which is also significant. Coming to the discussion part, the patients who had a Jamlan-BRCA mutation and metastatic pancreatic cancer that had not progressed during the initial platinum-based chemotherapy regimens had a significantly longer PFS with maintenance olaparib. The separation between the Kaplan-Meier curves can be seen from approximately 5 months onwards. The patient receiving olaparib had a 47% reduction in the risk of disease progression or death. At the end of 2 years, 22% of the patients in olaparib group did not have any disease progression, whereas 9.6% of the patients in the placebo group did not have any disease progression, which is twice. Patients received platinum-based chemotherapy immediately before maintenance olaparib. Therefore, this was a combined intervention. That is the first line platinum-based chemotherapy followed by a maintenance olaparib strategy, which has resulted in a PFS of more than 1 year among the patients with Jamlan-BRCA mutation who had disease that had not progressed while they were receiving the previous platinum-based chemotherapy. The strength of the trial is that this is one of the first trials in metastatic shape pancreas, which who has the maintenance intervention instead of a IV chemotherapy in the Jamlan-BRCA mutated group. The weakness is that the patients in the trial, they did not specify about the genetic testing, whether all patients need testing or whether the patients who had a family history should be treated, because we see that in CF pancreas, the Jamlan-BRCA mutation is less than 5%. So they had done BRCA testing, Jamlan-BRCA testing for all the patients, and those patients who are positive, they included in the trial. But this cannot be done in the clinical practice, because if the Jamlan-BRCA mutation, in the incidence of Jamlan mutation is very low, so it is difficult to prescribe it to all the patients. And somatic BRCA mutations were not done. So we do not know whether if the patient did not have any Jamlan-BRCA mutation, however, if patient had a somatic BRCA mutation, whether olaparib will lead to the same effect in the patients or not. So the opportunities, POLO trial is first of its kind study evaluating the role of a maintenance drug in a selected population with a metastatic shape pancreas, and significant PFS benefit with maintenance olaparib will translate into the standard clinical practice. Until now, there are no shifts to the study.
So we discussed that OS is around 11 months. Okay, 1 year you said. Why was OS 18 months here? Thoughts? 19 months in updated analysis.
Because when they did the initial OS data, sir, only around 46% events have occurred. So from the most of the deaths would have occurred by that time, sir. And the disease and the patients who did not have a such aggressive disease, so they are expected to live longer, and so
read at the hint given by Lingraj.
Bit more OS in the final analysis.
Read at the hint given by Lingraj just now. And first question of Akhil.
the good biology of these patients due to BRCA mutation. So they have already selected the patient. It is difficult to say whether this is entirely due to BRCA mutation or not, because they have already selected the cohort of patients who already have a good disease because they had not progressed on the first line chemotherapy.
Yes.
Almost around 30 to 40% of the patients, metastatic pancreas patients, progress on the first line chemotherapy.
And that they have already excluded.
Yes, sir.
Already 6 months patients who are responding to disease after 6 months were included. Practically, even the inclusion criteria said 4 months. So they have good selection bias that those who are doing good, they were selected. And overall, BRCA mutated patients do respond good to platinum therapies also. We have seen in ovary multiple times, or in TNBC, that if we come to know that it is BRCA mutated, we would love to add a platinum. So they are good chemosensitive disease. That is why also the biology, that way we can say that the biology is good. And in their inclusion criteria, that they have selected those patients who are doing good, who had still chemosensitive disease, were included in the trial. Okay. So any other doubts from others?
Yes, sir.
And what will be your final verdict? Will you use olaparib?
Sir, in case of metastatic pancreas cancer who had a germline BRCA mutation, we can discuss the pros and cons with the patient, and we can think of continuation of giving maintenance olaparib in the patient, sir. Because the first thing will be the cost, sir. The cost is also prohibitive in India currently right now, and secondly, in the trial, they have not given whether all the patients should be given this chance of germline, whether all the patients should be given all the patients should go for germline BRCA testing or not. So after discussion with the patient, then I think we can go ahead with the olaparib maintenance if they have not progressed.
Okay. Why do you want to give? So Shashwat, you were
Because though they don't have a overall survival benefit.
Shashwat was in favor of maintenance yesterday, right?
Yes, sir.
So will you give maintenance here with olaparib? And who was against? Ashutosh.
Yes, sir.
So what is your, will you give? And Ashutosh, will you not give? Is Ashutosh there? Yesterday you learned points. That is why I'm asking you all. Okay. So ideal maintenance therapy should be an oral therapy. So it is an oral therapy. Should increase PFS, ideally OS, but here it increases at least PFS. Cost is much, that is not in favor. The setting was very doubtful. Not giving a maintenance therapy was doubtful to patients. If you are comparing something, then you should at least, even in the placebo arm, I would have thought if they would have shown benefit over chemotherapy, I would have agreed that yes, even on compared to chemotherapy, there is benefit, but compared to nothing, there is benefit, and that too not an OS benefit, then obviously there many questions will arise whether to use it or not in daily routine practice. And another point is good amount of patients had toxicity. Around 40% of the patient had grade 3-4 toxicities, right? So it still remains controversial. Okay. Any data for somatic mutated? Any data that you are aware or anyone is aware? With any other PARP inhibitor?
Ovarian cancer, there is data, but in pancreas cancer, I don't know.
2 data with rucaparib, single arm phase 2 data. Okay, but with rucaparib. So even in somatic you can use, but obviously it is only phase 2 and single arm study. So here, if it couldn't show benefit, I doubt whether it randomized study over there will also show a benefit. Any other questions? So if none, then we will close the session.